So thank you all for coming to today's webinar talking about the myths and facts about mental health concerns in the senior population. I want to share that this webinar is not meant to be seen as diagnosing any mental illness or depression. If you are concerned about your own or someone else's mental or physical health, you will want to work with your own healthcare team to determine the best course of treatment. This is the perfect month to begin this topic because May is Mental Health Awareness Month. Although I believe that in the US, we are seeing more and more awareness on a regular basis, and it's no longer that we are kind of keeping this to a single month, and that's a really positive thing. And hopefully as we move forward, many of the things that we're going to talk about are reminders for those of you who are in the professional field and working with clients, and just kind of things to be a little bit more aware of. I want to start with a poem that was written by Richard Bell, who is a mental health advocate. And I thought it was really telling because I see any of these webinars, and particularly today's topic, to be really about a journey and really a map to really help those who are on this journey or walking beside someone who is on this journey to assist. And so his poem is actually called Map of Recovery. And he says, spreading out my map to recovery, I've noticed I've been going around in circles. Lost in my way, I do not know where to go, realizing I have to plan my way out of stagnation. I pull out a pen to put down some points. Great, I think to myself. Now I know where I'm going as I step back on my path. And it's my hope that after listening to some of the information today that you are able to be on a better path for your own recovery, your own well health, and the assistance to help someone else beside you. Mental illness is nothing to be ashamed of, and neither is talking about it. I think over time we have become a society where we are much more willing to talk about things that in the past have made us uncomfortable. So I just want to check, there's somebody who's having some sound difficulty and want to make sure that's not an issue with all of you. I'm only seeing that one. You can call in if you're having any difficulty on your computer. And that would be on the webinar registration, the phone number. So again, we as a society are beginning to have more conversations about things that make us uncomfortable, and I think that's a really positive thing. But as we move forward through the slides and the discussion today, I think we'll still recognize that there are points along the way that we have to continue to work at, and I think ensuring that this conversation doesn't stop with today's webinar is going to be the most important way to do that. And if every one of those that are on this webinar, and we have over 300 people who signed up for today, if everyone spoke about today's topic with one more person, we will continue to be able to ensure that mental illness is not a stigma that we can't move beyond. The reality is there is no health without mental health. And I think we often talk about mental illness and not focus on mental health, which again is a place of wellness, a place that we want to move towards rather than away from. It's so common it could be anyone. The trouble is nobody wants to talk about it, and that makes everything worse. At the same time that the over age 65 population in the United States is growing, the number of geriatric psychiatrists and psychologists is projected to decline, and that is along with the amount of physicians who specialize in geriatric health. and internal medicine, so that by 2030, when the number of older adults with mental health disorders is expected to be nearly double, the number of geriatric psychiatrists and psychologists is projected to be at less than one specialist per 6,000 patients with a mental health or substance use disorder. And I think that that is really a powerful statistic, particularly as we move through the slides and recognize some of the unique natures that and symptomology and treatment methods that those who are older adults who are experiencing symptoms of mental illness really require that specialization. So I want to talk a little bit about the objectives for today. We're going to talk about aging statistics. We're going to look at the truths and the myths. We're going to look at mental illness and aging stigmas as a whole. We're going to explore some of the specific conditions that are affecting seniors. We're going to look at depression, dementia, delirium, substance abuse disorder, anxiety, and some of the challenges to diagnosis and treatment, and the mental health first aid and resources that are available to assist you. What I think is key is, again, this is a very impressive list of topics to cover in 1 hour. So my reasoning for having so many different items is not because I believe that we're going to be able to really do any one of these full justice, but it's my hope that by introducing this topic to some of you, by kind of continuing the conversation for many of you, it will be that one more step and push to continue researching, learning, and assisting. By 2060, the number of Americans over 65 is projected to double from 46 million to over 98 million. 1 out of every 4 65-year-olds today will live past 90, and 1 out of 10 will live past the age of 95. These statistics are ones that many of you are familiar with. We've seen them on other presentations that I've done. You've seen them on other presentations that you've probably attended, as well as just in the general media. But I think it's always a staggering conversation to look at these numbers and really understand where we're going to be in society and how important it's going to be to, again, ensure that we have a true understanding of our later life development and the resources that can really assist us with those in this unique group. 6 million Americans over the age of 65 are affected by depression. The proportion of older adults living alone increases with advancing age, and among women aged 75 and over, almost half live alone. And that's an important statistic as we move forward and talk about some of the risk factors that are in place when it comes to depression. Over the next 2 decades, our aging population in the US will continue to be more culturally diverse. And that is particularly important because, again, at the same time that we're losing access to psychiatrists, psychologists, physicians who specialize in geriatric health, we also have to recognize that those who are working with the senior population have to have an increasing ethnic and cultural competence and an awareness of how these ethnic and cultural diverse kind of life issues impact diagnosis, impact treatment, and are part of the barrier to ensuring good health. The number of older adults with substance abuse issues is expected to double to 5 million by 2020. And I think perhaps one of the biggest aha moments that some of us may walk away from this webinar with is the discussion around substance use and addiction in the older population. But after all of that, we have to remember that as they age, people are generally more satisfied with their lives and more optimistic about growing older. And I think that that is one area that we need to hold on to, which is really key. As you write questions in the box, please know that at the end I will save time and we will review those questions. So let's talk about truth versus myth. There are many current beliefs about aging that were based on information that is no longer valid given recent scientific advances. So let's think about these. If you closed your eyes and didn't see the slide, and see how many of these you can get right. Most older Americans live in nursing homes. I think most of us know that that is a myth at this time, that only about 5% live in nursing homes at any one time. Most older adults stay socially engaged and productive. That is an absolute reality. Many older adults continue to work, volunteer, provide care to family members, and this regular engagement leads to better health, both physically and emotionally. Older adults have little or no interest in sex and intimacy, and that is absolutely a myth. Although frequency may decline, many older adults continue to enjoy healthy, fulfilling, intimate relationships, the benefits of which include better sleep, less stress, and more positive and emotional states. And again, these changes, these realities that we have come to recognize in our older population is so key because it changes the way that we deliver services, that we deliver care, that we develop and build new communities where seniors can live and flourish, is recognizing some of these areas. Individuals find it difficult to learn new skills in later life. And again, that is a myth. Older adults continue to learn new skills in later years, although some skills may take longer to learn than in younger adults. There is nothing that can be done to reduce the risk of Alzheimer's disease. That is a myth. Physical and mental inactivity, smoking, obesity, diabetes, hypertension, and depression have all been associated with an increased risk in the development of Alzheimer's disease. Depression is a normal part of aging. And thankfully, that too is a myth. Depression is not a normal part of growing old, but rather an illness that can be treated. Age alone is not a risk factor for depression. Older adults do not benefit from mental health treatment like younger people. Again, thankfully, this is a myth. 80% of older adults recovered from depression after receiving treatment that included both psychotherapy and antidepressant medication. And as we walk deeper into the slides and talk more specifically about depression, we'll share more information about that. Depression in elders is due to psychological and socioeconomic factors. That is a myth. Depression in late life is often a comorbidity, means that it goes along with physical illness, including but not limited to stroke, heart disease, diabetes, and hip fractures. You can add other chronic illnesses in there as well, of course. Because many believe that depression is a common part of aging, they do not seek treatment. The reality. Because many family members and even healthcare providers believe that depression is a normal part of aging and related to life events, such as the death of a spouse, they do not encourage or initiate diagnosis and/or treatment. But clinical depression is never a normal response to life events and should be treated as a medical illness. I learned this several years ago that there was still a misconception even among healthcare practitioners in terms of looking at the life stages of seniors and how they may play into depression as an actual clinical diagnosis. I had someone that was in my family friend circle who was an older gentleman, had lost his wife 3 years earlier to cancer, had been a very active individual, a very positive individual throughout his lifetime, and was really beginning to experience some symptoms of depression. And I was able to have a conversation and encourage that individual to go to a healthcare practitioner to have some conversation. But unfortunately, there was that myth that it was simply the sadness that he was experiencing 3 years later, after the death of his wife, that was causing this, and really was not looked at nor treated as a true clinical depression, despite the fact that had he been of any other age, I truly believe that he would have been treated in a very different manner, because this was not something that was it was certainly, there was sadness associated with the death that he had experienced 3 years earlier, but the symptoms that were coming were now falling under a depression and included many more aspects of his present life than simply looking back to 3 years ago, the death of his spouse. There is absolutely a double whammy when we think about mental illness and aging, because simply by itself, as we age, there continues to be ageism that individuals of many ages begin to experience. And you know, when we think about aging population, you know, we typically put an age of 65 and older, and I think we're going to slowly be seeing that differently. And the reality is there is no longer a single way of kind of looking at age. Someone at age 65 could be as active and as engaged in a work environment as someone age 30 or 40, or they could be retired and living a much more sedentary life. And typically it's going to be based on their lifestyle, life choices when they were younger. If you put a group of 5-year-olds in a room, you can pretty much tell that they are going to be in that 5 to 6 age range, depending on their size and their kind of how verbal they are in conversation. If you put a group of 75 or 80-year-olds in a room, you would not be able to identify their age clearly. You would have guesses from anywhere from probably 60 all the way to 100, based on their physical health, based on their cognition, based on their style, based on what they're doing on a lifestyle and work. So we continue to have ageism in society at the same time that we continue to have stigmas associated with mental illness. And we continue to have media discussions around mental illness being directly tied to some of the violence that has been plaguing society. And I think it has changed the conversation. It has opened up the conversation, but I think it's also done a disservice to what we've been able to achieve and accomplish when we think about our conversations around mental illness. There still remains many stereotypes about aging, about being competent, about being forgetful, and all of this leads into how we think about treating and diagnosing and supporting mental health issues in seniors. There's also, again, as I shared earlier, some ethnic and cultural competence and bias that is occurring in the healthcare settings, because there's not always a good and strong understanding of different, perhaps immigrant groups, different ethnic groups, and how they may be communicating or thinking about their physical as well as their mental health. And again, that overall stigma of mental health in the US does continue to exist. We see it just in the language that is used in terms of not utilizing terminology for a specific diagnosis, but people still saying, well, that person's just crazy. And while we often do it in a offhanded way, our language counts, and it sets up a tone, and it silences those who want to stand up and say, I am struggling today with my mental illness. So some of the issues that are facing the senior population when it does come to mental illness is certainly depression, anxiety. Alcohol, drug abuse, and addiction is falling under when you begin to look at mental illness. They really are looking at that substance abuse issue across all ages in that kind of category. Alzheimer's and dementia are often mentioned and included in a list of mental illness affecting the elderly. However, they are not specifically mental illnesses, but they can cause symptoms related to mental health issues, including depression, anxiety, agitation, and hallucinations. But again, we have to be careful that while they're neurological diagnoses, that we do want to think of them in some different ways versus just falling under the full umbrella of mental illness. But we are going to address dementia in this webinar. So what is depression? Depression is not sadness. It's not a case of the blues. It is a true medical condition that is treatable, like diabetes or COPD. What are the symptoms? Now, some of these symptoms do differ slightly when it comes to older adults, just like the depression symptoms in children is going to differ slightly from those in their teenage years and young adult to middle age years. But many of the symptoms you're going to see are persistent sadness over a longer period of time, a feeling of being slowed down, excessive worries, frequent tearfulness, feeling worthless or helpless, weight changes, both gaining weight, losing weight, changes in appetite, pacing or fidgeting, difficulty sleeping, difficulty concentrating, somatic complaints, physical pain, gastrointestinal problems, and withdrawal from social activities. Now, what's difficult and why we can imagine that diagnosing and having people acknowledge that what they're experiencing fits the depression is because there are several things on this list that really also are things we anticipate and expect as we age, even if they are not a normal part of aging. So that difficulty sleeping, we do know that there are changes as we age in our sleep patterns. So it's ensuring that we do the check, we talk with somebody to see if it is the sleeping alone in terms of the difficulty sleeping as your only symptom versus it being tied with some of these others. So independently of each other, this would not necessarily be someone who has experienced clinical depression, but when you begin to have several of these symptoms over a period of time with no physical reasoning behind it, that's where we begin to look at depression as a clinical concern. But again, it's important that whoever the healthcare provider and treater is really can separate those two and again, understands what is the normal part of the developmental stage of aging. Medical conditions, including chronic conditions, can trigger or worsen the symptoms of depression in elderly patients. So cancer, Parkinson's, stroke, heart disease, lupus, diabetes, as we've mentioned, dementia, Alzheimer's, and multiple sclerosis are just some of those. Medicine and depression is also closely tied, where some medications can be associated with depressive feelings in older adults and are often some of the warning signs for side effects for certain medications. And some medications specifically have stronger side effects in some older adults, just like they would in children under the age of 18, versus those who are taking that same medication but are in their young to mid-age group. So let's talk about what's called the 3 Ds: depression, dementia, and delirium. And I think sometimes the fear of dementia, where people are thinking about Alzheimer's, often get people to not even want to think about this or go to a physician, when truly there is some very different onset, course, risk factors, and signs and symptoms between these 3 Ds. So for depression, you're going to see more of a depressed mood, negative self-talk, lethargy, weight changes, sleep disturbances. With dementia, you're having a set of symptoms that can include difficulty with memory, disorientation of time, of place, of person, difficulty for performing familiar tasks and not being able to find things in some of the diagnoses. And delirium is more of a disorientation, mental confusion, emotional lability, manic-like behavior, hallucinations. It's the onset that is key in some of the differentiation. So depression, the onset can be weeks to months in a gradual way. With dementia, we're talking months to years, depending on the etiology. And in delirium, we're talking within hours or days. The course for depression is chronic. It can respond well to treatment. People can often have long periods where they are not experiencing any symptoms. Dementia is chronic with the potential for progression based on the reasoning behind the dementia itself. And delirium is acute. So it usually lasts 1 to 7 days. It is usually temporary, and it does respond to treatment, but it is very important that treatment happens when the signs are occurring. There's a risk factor for depression, which can be family or previous history, physical pain or diagnosis, medications, stressful life events, lack of a social network, and substance abuse. With dementia, there can be a family history. Some medical conditions can bring on forms of dementia, such as vascular disease. There's changes in brain and diseases such as Parkinson's. Delirium, again, is often going to be due to medication interactions, a history of drug or alcohol use, poor nutrition and hydration, illness or surgery, or a urinary tract infection, or some other type of sepsis or infection in the body. The information that I'm sharing is certainly not for you to be diagnosing anybody unless you have the credentials to do so, but hopefully to, again, just bring an awareness of these areas and concerns so that we can help guide somebody, whether family, friend, colleague, or client, into the right treatment and the right service providers. So let's look at anxiety in older adults. Between 3 to 14% of older adults meet the criteria for a diagnosable anxiety disorder. However, when you really begin to look through the material and look through the research, there are many who believe that this is not necessarily a true reflection of the prevalence, due to, again, some of the similarities with what we see with depression, that some of the symptoms that are coming up with anxiety, we often relate to what is anticipated to be normal aging, even though it is not normal aging. Anxiety that causes changes is something that causes changes in daily activity and functioning, and again, is not normal at any age. A history of anxiety over time can be a risk factor in later years. So while it is less common for people to have a clinical anxiety, a general anxiety disorder that they haven't had in the past with any previous history of such as we age, while it can happen, it is definitely not as common. Recognizing an anxiety disorder is more complicated in older adults because many of the physical symptoms one can experience with anxiety, gastrointestinal upset, headache, changes in heart rate, are misdiagnosed as a symptom of another medical chronic condition that may be something that somebody is experiencing. So you can understand how this becomes much more complex, and why, again, the lack of specialists in the geriatric field is such a kind of concern, because we really do have to very closely look at what fits into which category. So let's talk a little bit about aging and alcohol and drug use. 2 to 4% of elderly meet the current criteria for alcohol abuse or dependence, which is about 5 million older adults. However, there's an additional 10 to 15% of the elderly that meet criteria for at-risk drinking. This is a really key statistic, that 6 to 11% of elderly hospital admissions is due to alcohol or drug problems. And I think that's really important to understand. Depression and alcohol use can increase with age, and the way that it impacts the body, the way that it's processed through the system, is also more complicated due to other chronic age-related physical diagnoses. Past history of addictive disorders may increase the risk for central nervous system disorders such as depression or dementia. And there is an anticipated rise in substance use disorders in older adults that is expected to almost double between the years 2002 and 2020. So we are very close to this top end number of 5.7 million older adults experiencing. We see, just as a overall societal concern, this rise in substance use, particularly when we think about not illicit drugs, but when we think about prescription drugs. And we're seeing changes happening every day in the healthcare delivery system when it comes to the prescription and physicians prescribing opioids and other medications that do have a higher incidence of substance abuse. So we are seeing changes in this, but again, I think there is often a misunderstanding, a myth, an ageism that seniors would not be misusing medications, that is for the young at heart, that is for teenagers who are experimenting and exploring. But it's very important that we recognize this concern as much as we do with some of the other mental illness diagnoses when we are having conversations with family members, with friends, with clients, and we're really watching for some of the signs that could be occurring. I think there's also a concern that happens that people don't want to have the conversation. It's hard enough to talk with a family member about the overwhelming sadness, the overwhelming kind of depressive mood that somebody may be experiencing and being concerned about that. Talking to someone about substance use or abuse is even more difficult for most people because there's at what point does it reach a certain level? And at what point is it that it's overuse? Or is it that, again, someone's body just wasn't processing it well, or it had an misinteraction with another medication? So we try to find reasons that we don't have to have these type of conversations. There are more and more specialized drug and alcohol programs that are specifically for those over the age of 65, because the stigmas associated with alcohol and drug misuse is great. And so really needing to have those in a similar cohort really be able to have the opportunity to communicate with each other, because many of their life experiences, life events are similar, versus if you have 80-year-olds who are dealing with alcohol and drug use and 18 through 30-year-olds. Life experiences differences are key to how they are going to move beyond the substance abuse and addictive behaviors and get to a place of health. Suicide, something, again, probably one of those areas like drug and alcohol abuse that is even harder to talk about. Among males, the suicide rate per the National Institute of Health was the highest for those aged 65 and older. And the rate of suicide in the oldest group of white males, ages 85 and plus, is over 4 times higher than the nation's overall rate of suicide. Something that has always impacted me from many years ago when I began to have conversations and put on webinars in regards to this topic is that 64% of people who attempt suicide visit a doctor in the month before their attempt and 38% in the week before. That is really powerful. It shows that as a healthcare delivery system, we are not asking the right questions. We are not looking at the triggers. We are not having the conversations that are needed to have. Elder suicide may be underreported due to silent suicides. There are many deaths that occur in elders that could be from suicide, from a voluntary choice to stop eating, to not take medications, at choices that are being made that are creating really their death. So there is a strong belief in the research that elder suicide is underreported. It is so key that we all learn the clues to a potential suicide and always take them seriously. Suicide is something that we see and hear every day in every age group, and more we're seeing it in younger population where we would never anticipate that a 7 and 8-year-old are committing suicide, often due to bullying in a school or online. And so suicide continues to be an epidemic and continues to be something that we all have to be aware of. Do ask directly if someone is thinking about suicide. And if it is not something you are comfortable with, then have somebody else start that conversation. Take action. There is nothing, if someone is saying, well, I really don't think I want to live any longer, life is not worth living, and we're just trying to say, oh, Mom, you don't mean that, stop saying that. You need to take that seriously, and someone who has the healthcare credentials, someone who has the skill set to really identify, is this suicide ideations, needs to be involved. And even if someone is not going to actively try to commit suicide, just by saying those words, we clearly recognize that there is a concern. There is a need, and somebody is asking for help. Do be non-judgmental, and don't lecture or try to convince somebody that life is worth living. This is where professionals need to be involved. And if needed, and someone begins to share information about wanting to commit suicide, if they have any means available to them, if there's guns in the home, if it would be easily accessible, you need to get the emergency response providers involved immediately. So what are some of the challenges to diagnosis and treatment? We've kind of talked through some of these as we've gone along. But one of them clearly is that mental illness, especially depression, is seen as a normal part of aging. There's still, because there is this sense of, well, who would want to get older? Who would want to grow feeble? All of those ageisms, all of those stereotypes lead us to believe that, of course, people are going to be depressed. But clearly, we started with the first line in the first, or the last line in the first slide, which said that older adults have more satisfaction in their lives than other generations. Many of the clinical indicators of depression are associated with false and stigmatized beliefs about aging. There's a stigma associated with being mentally ill, especially in our present senior population. They have lived with, and many have survived the depression and other kind of life and societal events where the idea of pulling ourselves up by one's bootstraps is what makes somebody strong. And so having to admit anything other than that, and particularly anything that is associated with mental illness, is very difficult. There is a fear with this population that with diagnosis would come a push for control over finances and healthcare decision making from both family, the court, and healthcare providers. And because so many seniors are concerned that they will have to be moved out of the home that they have chosen to reside in, that is another reason that if we keep this hidden, then I'll be able to stay where I'm at. The lack of geriatric healthcare providers impacts diagnosis, treatment choices, and the understanding of lifespan development, which is going to be key and necessary in the diagnosis and treatment of mental illness in the aging population. Treatment can be more challenging because of the interactions with some of the medications people are already on. And certainly there's an economic concern for treatment around seniors. How much more do I have to pay for medication? I already am struggling to pay my medication costs now. There's a concern that Medicare won't cover mental health treatment, and we are continuing to see improvements in the healthcare delivery systems and in insurance programs that cover, and there's parity with mental health and physical health treatments. It's important that we understand why someone may be concerned to move forward with talking about diagnosis and treatment, and if it is for economic reasons, that we have to assure them and show them how this is not having to be the concern that they are worried about. So what are some of the ways and the first aid for mental health? ALGEE, A-L-G-E-E, is a mnemonic device for mental health first aid's 5-step action plan. And this is from the National Council. A stands for assess for risk of suicide or harm. L, listen non-judgmentally. G, give reassurance and information. E, encourage appropriate professional help. And finally, E, encourage self-help and support strategies. It is really key that if you are a professional working in any environment where there is a large group of seniors or those of any age, that you understand how to have your team kind of know these 5 letters. And again, while it is not their place to treat, to diagnose, it is important to ensure that we are getting the information and sharing it with the appropriate professional providers. There are a number of resources and tools that you can utilize when it comes to exploring more about mental illness in the aging population, as well as to kind of work with any of your team members as a family member to really look at your viewpoint on aging in general. It is not just for what we can bring to the present generation, but if we, as we age ourselves, have a better understanding, have normalized what is truly going to happen as we age, don't have the same fear about what is going to occur, we are going to ourselves have better mental health, and we will reduce the continuation of ageism. Because the reality is that ageism is not something that simply happens from one age group to another, but there is much ageism within the senior group themselves. And that you know that because there's a lot of self-deprecating humor. There's a lot of, kind of conversation about, age and wrinkles and memory and all of those things coming from individuals who really are healthy, but they have turned society's view of kind of getting older and all the things that are believed to happen and all those stereotypes onto themselves. So the way that we can combat ageism is that as we age ourselves and as we raise our children, that we continue to provide them the normalized view of aging. We really begin to remove the images of the harried and incompetent older characters just because they are older. There's some great websites and some quizzes that I think are really helpful, and it's a good way of kind of seeing where you fall within the kind of continuum of understanding what's normal aging and what's not, as well as how and where your bias may be. There's a Facts on Aging quiz, and the website is listed. If you or someone in your family, friend group, or at work or a client, if you have any concerns about suicide, suicide ideations, please contact somebody. One such location is the Suicide Prevention Resource Center, 1-800-273-TALK. There's a project around the country, and I know that Washington State is doing many projects around No Wrong Door. And these are really health facility initiatives that are trying to ensure that no matter where someone goes within a healthcare provider, where someone goes within a hospital setup, where someone goes within a clinic, that no matter what door they step through, no matter what practitioner they work with, that individual is going to be able to help guide them and seamlessly ensure that they are passed to the people that they can benefit from. So this is happening both with some aging mental health projects, as well as a big push within the veteran community. So if you look up No Wrong Door Projects US, you will find some projects in your state. There's 2 ageism quizzes that I have websites for as well. And these will really, again, I think for your team, for yourself, for family members, are a great way to kind of test your knowledge and test how your bias may be impacting you. So we're going to take a moment to review the questions. Please feel free to continue to jot those down. I'm just going to mute the phone for 1 minute as I review these and then read them out loud and provide some answers. Okay, so one of the questions is that someone is caring for a 95-year-old family member, generally in good health, has regular doctor checkups, dental hygiene. However, she has a very difficult time getting out of bed, standing up from sitting and walking, often mentions having an upset stomach. She has seen her physician for these things, but would any of this benefit from visiting a psychologist? You know, I never want to say don't reach out to a healthcare practitioner. You know, it's certainly something that you could explore. If she is, you know, I would really just have some additional conversation with her. Is she experiencing that sadness? Is she isolating herself from family members, even if she's not able to get out, but when they want to come and visit her, is she isolating herself from them? Are there things that she wants to do or not, like she would normally like to do and is no longer doing them? And is she not doing them simply because of the inability to access those, or because she doesn't have the energy to do those and there's a lethargy, or she no longer takes pleasure in some of the things? If you're starting to see some of those issues arising, then it would be something that at her next physician appointment could definitely see if there's someone who would maybe have more of a conversation with her. Certainly the more activity that she could have, the more engagement with others, even if it's just, a visit once a week, even from a companion who could do some of those things with her that she enjoys, but bring them more in-house than having to go out into the community if that's difficult. Again, I never want to say it's not something she could benefit from. And the reality is that sometimes having somebody to talk with from a emotional perspective really is a good thing to do, whether you have any kind of clinical mental illness or just are wanting to have an ongoing engaged relationship with life around us. So those are some of the things to think about. Someone asked if there's a relationship between dementia and Alzheimer's. So Alzheimer's is the most common form of dementia. So where dementia is more of a category of symptoms, Alzheimer's would be one of the diagnoses that really fit under the umbrella of dementia. Sometimes healthcare practitioners will give the kind of quote unquote diagnosis of dementia because they have not been able to isolate more of the specific kind of risk factor or the reasoning behind it, whether it's Alzheimer's or vascular dementia, so that they kind of stick with the more of the symptomology of just the saying it's dementia, because it's really more about how is it impacting the day-to-day life versus it changing the way that a diagnosis would be treated. Someone asked if there's a list of medications which commonly have side effects of depression. Well, I don't have that list. Certainly, it's something that if you have any concern about any of the medications that you or somebody is on, talking with their pharmacist is a great resource. I think we sometimes forget the level of knowledge that the pharmacists have that we pick up our meds from on a regular basis and see in our large corner drugstore or grocery store. But pharmacists really have a very comprehensive knowledge base and really are keeping up on all of the different medications, side effects, et cetera. So you can definitely have that conversation with them. There are things that you can find online. However, always be concerned with kind of taking online medical advice, and it's really most important to understand how some of these things are interacting with each other versus it standing alone by itself. So looking at kind of psychotherapists for elders, certainly many of the National Institute of Health, some of the national mental health associations will have lists of practitioners under their specialties. I would absolutely, if you are going to be reaching out to any psychologist, psychiatrist in your community, is to really understand what their specialty is, what population they tend to serve. Oftentimes, you may start with the hospital setting and talk with one of the behavioral clinics. Most hospitals will have a psychiatric clinic, both inpatient as well as community-based, and you can start there. Sometimes those psychiatrists will see patients individually, or they can recommend someone in the community that does have a more specialization. If you are working with a physician who has a large base of aging patients, they may also have a list of clientele. Getting a few more questions. My mom is 95 and we started seeing dementia symptoms last year that are now increasing. Are these types of symptoms normal and can be considered old age? So while the percentage of those diagnosed with dementia and Alzheimer's type conditions do increase with age, and certainly someone who has lived 95 strong years has a higher incidence because of the longevity that they've lived from. It is not that age alone is the factor that would be increasing this. So again, dementia and Alzheimer's are not a normal part of aging. However, as we age, we do see a higher incidence of these diagnoses just because of some of the reasoning behind the diagnoses themselves, changes in the brain, which are happening just as we naturally age, some of the impact of other chronic or progressive illnesses, which can create some of these other brain changes. So again, it's not about the age, although she does have a higher risk factor as her age increases. So it gets a little kind of convoluted, I think, when we think about it. And I think it's easy to understand why we often do see those age related, even though it's not the normal part of aging. It is really thinking about, needing a hip replacement is not a normal part of aging. But as we age, we do have changes in bone density. We do have increased risk factors for falls. So there is an increasing risk as we age for hip fractures, but having knee replacement or things like that is not a normal part of the bodily aging. Any concerns with inpatient behavioral facilities for elders? I'm not sure what this individual means by concerns, but I think that there are certainly times where somebody can really benefit from an inpatient behavioral facility, as someone could benefit in younger years as well. I think just with any kind of facility, we always want to understand who is directing it, what the specialties are. Is there a geriatric psychiatrist? Is there a geriatrician who is, board certified with specialized training? What different training do staff members have? But I have seen people greatly benefit from being in a controlled environment to allow the team to really assess what behaviors are happening, what the triggers are, if they need to wean people off of previous medications in a safe way, and then slowly begin to introduce some other medications and monitor how they are benefiting or burdening somebody. So there's definitely some things that someone can benefit, particularly if there is any concern that they are at risk to themselves or others in a general community-based program, or in their home or in another level of facility. So someone asked a really, I think, key question. If a parent is resistant to psychological intervention, should the caretaking child go to a psychologist or counselor? I think that we absolutely can benefit if someone else is adverse at that time to having and going to seek any kind of treatment or have any conversation with a psychologist. Those who are providing care to them, those who are having, their closest relationships, can absolutely benefit from their own conversations with a psychologist or a counselor. It is key to note that that individual would not be able to diagnose, would not be able to put a treatment plan in place for the other person, however, without seeing them, but would be able to give you some better tools and maybe some different conversation starters to encourage that older adult to attend counseling. I also think that one of the things that's really key is that we should never ask somebody else to do something that we are not ourselves willing to do. And I think when we say to somebody, Mom, you're not doing well, you're too sad, you're too depressed, you're too something, you need to go to see somebody. And I'm certainly not saying that this is the way that this individual approached it, but that's really the person hearing that message hears, you're feeble, you're weak, I'm going to take over and control the situation. it's often very productive to say, Mom, as I've kind of gotten older, as I'm going through some life event changes, I'm starting to go to a counselor, and I found it really beneficial. And what they shared with me is they would be willing to have any other family member that I think, that I have a strong relationship with, attend one of my sessions. So oftentimes people are more willing to do something if they know you as well are willing to do it. And it normalizes it, because if they see you as mentally healthy and as emotionally strong and still taking that step, they will be more comfortable in taking that step as well. And knowing that they could come with you is important. So it's something, if you do look for a counselor, you will want to ask up front. One of the things I want to talk about is kind of my mom and how I'm interacting with her. Is there an opportunity, if she would agree, that she could attend one of the sessions with me as we move forward? So if that person does work in that way, then it would be a good opportunity to at least leave that door open. I don't see any other questions at this time. I really appreciate all of your attention. I hope that this topic has been kind of a little mind opening and given you some things to think about. As always, if you would like to receive a certificate of attendance, please email me at Carla, C-A-R-L-A, Sutter, S-U-T-T-E-R, at synergyhomecare.com.